It's a great day to talk rehab. I'm Dr. DeFabio, and today it's clinical rounds. That's right, we're doing clinical rounds to help you diagnose the elbow and treat pain on the outside of the elbow. So that's what it's going to be all about. Before we can do any intervention, we have to find out what's wrong. So the patient's coming in with pain on the side. By the way, Jessica, say hi to everybody. There you go. You guys don't have to look at me. Everybody can look over here. I'm just going to talk about the elbow. Keep smiling. No, thanks for your help today. Lateral outside of the elbow pain. What's wrong? Is it ligament? Is it nerve? Is it muscle? Is it pathology? Is it a trigger point? That's what we have to find out. So first is assessment. Inspect the area. Is there trauma? Was there trauma? Did they wake up like that? Was there prior injury? Those are the things you have to go through. Always a consult and a history first. After inspection, we can check passive range of motion, looking for pain, okay? In rotation, supination, pronation as well, all right? Be aware that pain here can be referred from the rotator cuff, can be referred from trigger points in the neck, can be referred from trigger points in the infraspinatus muscle, as well as being a radiculopathy, all right? This is going right down that C6, 7 nerve root, so always check the spine. That'll be next. Locally, once we inspect it, we do passive ROM. It's about active ROM. Bend your elbow. How far can it go? Straighten the elbow. Can you turn down? Can you go palm up? Pronation, supination. Full range of motion is the next thing we're looking for. If passive range of motion is less than active range of motion, that would be a little suspicious that something unusual is going on. Passive range of motion should be more than active range of motion unless there's a joint locking, unless there's a blockage at the radioulnar joint, at the little cartilage that's in there, or there's too much swelling, but there's something preventing joint motion. But in general, passive ROM should be slightly better than active. If we think that there hasn't been trauma, we don't need imaging, then we can go on to checking some muscle tests. Now let's talk a little bit about imaging. If there's been trauma, imaging is indicated, and it may be plain film radiographs. Beyond that, if you're concerned about the soft tissues in the elbow, the forearm, your best diagnostic test of choice is MSK ultrasound, musculoskeletal ultrasound. Find a doc in your area that does it, refer it out, send it to the local imaging center for MSK ultrasound, and they'll be able to tell you the integrity of the soft tissues. Is it a tendinitis? Is it a tendinopathy? Is there an entrapment of the radial, superficial branch of the radial nerve right through here? So those are all things that you have to decide. You can come up with a working diagnosis in the office, but if you feel diagnostic imaging is warranted, MSK ultrasound is your best bet unless there's been significant trauma or you're concerned about the underlying tissues within the joint. So, what about the muscles in the area? Well, let's see if it's a contractile issue or a non-contractile issue, meaning the ligaments in the capsule are non-contractile tissues. If they are pain with passive range of motion, then we're straining the non-contractile issues. If there's pain with active movement, then we're straining the contractile tissues, the muscle, the tendon, the myotendinous junction. So let's check the elbow first, just with wrist extension, and you ask for pain with the elbow flexed. Then wrist extension with the elbow extended, pull up. That's checking the longer common wrist extensor fibers. This is shortening the common extensor tendon fibers that cross the elbow. And here, when you do wrist extension, you're not challenging that. So if this is painful and extend, this is not painful, that tells us the problem is in the extensor digitorum brevis, radialis, ulnaris, one of those guys, the shorter muscles that don't cross over the radial head into the ulna. Wrist extension, hey, the orthopedic test for this is the middle finger sign, push up, and that will also strain it right there. Push up, I do all the fingers, push up, because the extensor indicis, push up, and the ulnaris still have different attachments. Resisted motion that way, but what about in supination? Straighten the elbow, supinate, push, turn up for me, please. Resist it. Not usually a problem, but maybe there's other pathology. We have to assess the whole area. Just because the pain's here doesn't mean the problem's there. Now, what about turn down? Pronator, okay? Also, right in through here, medial epicondylitis, more of a problem. But we did supination. What's just underneath the supinator is the superficial branch of the radial nerve. So it could be an entrapment syndrome. Supination can also be tender if there's a problem with that common extensor tendon as well. We're not done yet. We need to do extension, push towards me. Triceps and encodius can both give elbow pain on that lateral aspect, so you need to check for that. However, we still need a couple of elbow flexors we need to do. Plain old biceps, pull towards you. Brachioradialis, pull up towards you, palm down. Brachioradialis is here, hammer curls. Brachioradialis is this one, and then brachialis is here in pronation. Why do we check them all? It tells you what soft tissues you have to address. With your hands, if you're doing soft tissue release, with your instruments, if you're doing instrument assisted, and if you're going to follow up with kinesiology taping, where to go. We know the brachioradialis crosses both joints. Bingo. Pain's here, all right? It crosses both joints. We know we got to hit the brachioradialis, all right? If it doesn't affect it when the elbow's extended and only when it's short, I'm not concerned to break the brachioradialis, but the brachialis might be involved, or it could just be the common extensor tendon. So you need to know your anatomy so you can do a thoughtful approach to your rehab. However, remember, turn just sideways a little bit for me. Trigger point back here will referred pain into the elbow. Trigger point in the anterior scalenes. Doorbell sign. Palpate the anterior scalenes. Any referral of pain down the arm? Yes, no, but oftentimes that can refer right down the arm as far as the wrist. So you have to look for entrapment syndromes here too. You have to rule out pathology in the cervical spine as well. Once we've done all that, we've come to a working diagnosis that there's a lateral epicondylitis. If it's more acute, then we would proceed right away with some eccentric loading. If it's more chronic, we can suspect there's a tendinopathy, which is a degenerative condition of the tendon, where we want to get some flexibility to stimulate those fibroblasts to start laying down some high quality tissue. So let's assume it's the worst case scenario. It's pretty hot and somewhat chronic. Let's go with some simple stretches. Waiter's tip stretch is the first stretch. Just like a waiter looking for a tip, getting a nice, comfortable stretch in through here and really rotating that wrist around. Nice. How long do you hold it for? 20 seconds, but you do it a lot. So you do it a little bit, 20 seconds, but a lot, maybe every hour. You're training the same fibers of the biceps that go 15 degrees above and below that. So when you're in the acute phase, you want to go right up to that point where you feel it a little bit and start doing those finger squeezes in all different positions of the hand. However, those are flexors. Oh, there goes our ball. Good catch. Those are flexors. This is the common extensor tendon. Why are we doing that? For a couple of reasons. The common extensor tendon has to stabilize the flexors when you flex. So you do get some, that's why you can't shake hands, because when you squeeze, this has to stabilize, all right? But we have to hit the extensors. Level 1 extensors, take a yellow CLX, open it up, put your fingers in there. I'm Italian, so I go, what do you want from me? So what do you want from me? I want you to train your extensors. So wrap it around, I'll let you do it. Hold it, yeah, right about there. Open the fingers and close. In all different combinations, these 2 fingers, those 2 fingers, pinky only, thumb only, all the fingers, but the same concept. All different hand positions and arm positions so you can load those fibers right up to the point where they're irritated, but you're not overloading them. It's called maximal loading. We want to get it up to that point where we can maximally loading it for what it can tolerate. Now, if you can't tolerate this, this might be too much. You may have to just do a hair tie and something really light. A couple of minutes a day, but all different positions up to that point where it's a little sore. Level 1, lateral epicondylitis treatment. Once you get out of that really hot phase, we know that the best treatment of choice, research says, is the Tyler twist. That's where your flex bar comes in. Tyler twist for lateral epicondylitis, well evidenced, grab it like you're holding a microphone, extend the wrist. Doctors, we know the best treatment of choice for tendinopathy is eccentric loading, right? So this is going to be eccentric loading. Concentric loading is going to strain it, it's going to hurt it. We don't concentrically load tendons, all right? We want that tension over time with the release so we can get the fibroblasts and the collagen fibers to go in the direction we want. So we concentrically load with no resistance. Grab over the top, turn away, all right? Nice and tall. Bring it around the front, straighten the arms. This is still an extension. This hasn't done anything. This is just doing an isometric. The injured side is just doing an isometric. This is the kicker. Slowly let it unwind. That's it. Eccentric loading of the common extensor tendon for tendinopathy, tennis elbow, lateral epicondylitis. Relax. Let's do it again. Here, slow for everybody at home, Jess. They know you don't. Extend, okay? Stay tight. Over the top, rotate away, keep it tight. Straighten it out. This is what we're looking for. Unwind. That's the ticket. 3 sets of 15. When you get up to 3 sets of 15, go to 2 sets. Go to 3 sets. 3 sets of 15 twice a day. When that gets easy, you can go to a harder resistance, a heavier resistance, flex bar. Yellow, green, blue, they go the same progressions as our stretch bands. As that improves, what if they're a tennis player? What if they're an overhead athlete? What if somebody that needs to use their arm more? Well, we can use the flex band and we can use some resistance tubing. With the flex band, we can do some simple perturbations. Arm straight out and just go back and forth. Just wiggle it. Now, I really like the red. Go ahead, wiggle it. Go ahead. I really like the red and the yellow flex band, flex bar for this because it really wobbles and then goes side to side. Now, if they're finding it, they're getting more activation, going laterally versus sagittally versus coronally, whatever they get, that's what you want to do. I start with 30 seconds, building up to 2 minutes if you can, but at least a minute. Then you got to go up to Statue of Liberty position, way up top high. Same thing, flex back and forth, sideways. Nice, good way to get those perturbations. However, if it's somebody that's doing racket sports or there's going to be repetitive strain, let's get a little more functional. Now we're into that rehabilitative, that's great, Jess, that rehabilitative return to function phase of care. And for that, that's where our CLX band comes in really, really handy. So when we go to the rehabilitative and return to function phase of care, let's say Jessica's going to be a tennis player today, all right? So let's say you're going to do a backhand. So stand sideways. I'm going to be the resistance, face that way, all right? So you play tennis? You do now, okay, all right? So over here. So just get a nice ready stance for me, nice ready stance, and give me a backhand swing. Bingo, okay? Backhand swing. So if she's a tennis player, she can duplicate her exact tennis swing with the CLX tubing, all right? Now, let's say she has a tendency of poor technique in tennis, and with her backhand, she flicks her wrist, all right? So go do your backhand and give me a little wrist extension at the end, just wrist extension and recover, all right? Backhand and a little wrist extension. That's if she's got bad technique, but that's what created the problem. To correct the problem, we're gonna wanna have you just do functional movement patterns, all right? And that can be for anybody with any situation. So the flex bar is for that, gets you into the rehabilitative phase of care, then your CLX is your return to function phase of care. However, flex bar perturbations are essential for those rapid snapping motions that people need to use when they're doing plyometrics, push-ups on their hands, CrossFit type of activities. When they're doing the plyos on the arms, that's when all that comes in. So you have your adequate assessment. You got to know what structures you're looking at. Is it ligament, tendon, disc, nerve, referral, pathology? Second, subacute, acute phase, get the inflammation down, shut that down, that inflammatory cascade, and a little bit of stretching, gentle exercises, always submaximal loading. Third, get them in the flex bar as soon as possible. Fourth, get them into perturbations using the CLX. And then send them back to return to play. That's all you need to know to rehab the elbow. It's been a great day to talk rehab here at the Performance Health booth at Florida Convention. Have a great day. I'm Dr. DeFabio and Jessica. Thank you once again.